Good evening, sir. I, Shuman, on behalf of Shield Healthcare, welcoming you and all the participants in today's webinar. And the topic of the today's webinar is menopause and its treatment perspective. Before moving into the webinar, let's have a look on our Shield Connect, that knowledge sharing platform. This is our Shield Connect page. Here you can find different blogs written by many eminent doctors. Here you will find all the past webinars we have already carried out in our platform, and this is the important one that is in this COVID era. This is the immunity boosting blog, and here you can find the immunity booster blogs in different topics related to the respiratory tract. And this is our PCOS awareness program. Here you can find many eminent talks of different doctors regarding the PCOS, and you can find it that many languages are available regarding English, Hindi, or Malayalam, many regional languages. And the most important thing is our key opinion leaders, and presently almost 250 leaders are currently supporting our platform. So I request all the participants, please go through this website, as it is a very informative website regarding our subject. And now it's time to start our webinar. And today's webinar topic, as I mentioned already, that is menopause and its treatment perspective. And our guest speaker is Dr. Apurba sir. And it is my pleasure to introduce sir. Sir is MBBS, MS Gold Medalist, MBBS, and FIAOG, FMAS, RCOG Associate, PGDHHM, FMAS. And sir is the consultant of obstetrics and gynecologist and currently associated with Sri Durga Clinic and Fertility Center, Dhanbad. Sir is the winner of Dr. Kamini Rao Yuva Orator 2020. Sir is the winner of National IMA Community Service Award for Individual 1920. Sir is the Padma Bhushan Kamlabai Hotpet Award 2019. Sir is the winner of Fox's Traveling Fellowship Award in the year 2017. Also Fox's Basant Ben Shah Fellowship for Overseas Study 2018. Sir is the National Coordinator for Fox's CMEs or Workshop for Safe Abortion and Contraceptive Cafe 2020. National Coordinator is John Fox's Adolescent Health Committee 2019-21. Is the coordinator for Foxy Sexual Medicine Committee, Jharkhand and Bihar, and National Coordinator for Public Awareness of the committee. So is the regional faculty and master trainer, TOT Sat, Foxy IAP Initiative, and executive founder member of Jharkhand State Chapter of International Spina Bifida Foundation. Sir is the faculty, speaker, and panelist in various national and international conferences. Apart from that, sir is also active in many research related things, sir has many papers to various international and national journals. Out of that, one chapter is on hysterectomy, myomectomy in textbook of hysteroscopy by Dr. B. Ramesh by JP Publications. Another one is the pneumococcal vaccine during pregnancy in Foxy Fetus 2017. Sir is the editor-in-chief in news letter of Foxy Sexual Medicine Committee. Apart from that, sir is associated with many local society, that is member of organizing body Obstetrics and Gynecological Update of Uttarakhand 2013. Sir is the member of organizing committee of Foxy's first international congress on why mother die in utero 2017, and sir is the organizing committee of Foxy World Yuva Summit 2019. With this short introduction, I request sir to take over the session, and meanwhile I request all the participants to please put your queries on the QA dashboard of our Shield Connect page. So once the talk will be over, so we shall have a short discussion with sir. So thank you, sir, and over to you.
Thank you so much, Sumanji, for your kind words, kind introduction. So without wasting the time, let us begin today's topic, that is the menopause. All you know, the treatment perspective. Let me share my slides. My slides are visible. Suman, my slides are visible?
Yeah, it is visible. Make it full. Yeah, now it is visible, sir.
Okay, okay.
Thank
you so much. Okay, talking to menopause. There is a famous saying that a woman should fit at 40, strong at 60, independent at 80. But the menopause always actually called it as a, not as a hindrance, but definitely a big problem in this saying. Why so? Because affect almost each and every aspect of a woman, whether it is the social, whether it is the mental, whether it is the physical, whether it is the body, and it adversely affect each and every organ, each and every function of a woman. But my dear friends, we all know that menopause is not a disease, it's not a deformity, but it's a physiological phenomena. So we should all know about the menopause, what actually menopause is, what actually we should learn about the different symptoms, signs the menopause cause, and what the pharmacological as well as non-pharmacological therapy deal with the various problem with the menopause. Now, begin with what actually is the menopause? Menopause is the permanent cessation of the menstruation, which is confirmed only after 12 consecutive months of amenorrhea. So, my dear friends, we always see that in our OPD, a lady come and she told, Doctor Sahab, I don't have my periods from last 6 months. So, do I attend the menopause? So, my dear friends, it is not. If it is 12 consecutive months or more, then only we called it as a menopause. In general public, it is the average age is between 45 to 55 year of age. But in Indian population, it can be vary from approximately 42 years to the 50 years. But in national data are saying 80% of currently married women as a age group of 30 to 49 years can reach menopause, and it is a recent trend we observe by Indian Menopausal Society study that the menopause age in many places and in Indian women is actually reduces. So, but the overall till now it is the 42 to approximately 50% is the average, 50-year is the average age of the menopause. Now, the concern has been expressed regarding the, as I already told, the premature menopause, that is the menopause below the age of 40 years. For example, a data is saying that in case of Andhra Pradesh, the 22% of the women in the age group between 35 to 39 year actually attain the menopause. No, keeping this data aside, just I want to emphasize that when a lady is come with the different symptoms of menopause, we should not ask the array, she is less than 40 and she can't be in a menopause. No, this not. If she has the symptoms of menopause, even in a early age, we should regard this as a menopause, as a natural menopause, and we should treat the patient as a we are treating in a menopausal lady. Now, what is the physician role in approaching this type of patient? Now, the most and foremost thing is each menopause lady has her individual treatment protocol. That means maybe one lady has come and she has the symptoms of hot flushes. Maybe some another lady, she doesn't have the hot flushes, but she has a tremendous back pain or the pain in the pain in the limbs. That is the symptom of the osteoporosis. Now, one may come with the symptoms of the dementia or some depression or some sexual function. So it is not sure that a single protocol is there for every individual. No, it's not in case of menopause. The every menopausal lady should have her individual protocol, and we should consider it according to symptoms or the primary symptoms of the patient. Now, what is the basic symptoms of the menopause? The symptoms can be divided into vasomotor symptoms, somatic symptoms, urogenital symptoms, and the neuropsychiatric symptoms. We will talk about this one by one. Now, menstrual symptoms is actually patient often observe there is a shortening of the cycle in the late reproductive age group. This is actually the clinical marker of the onset of the menopause. Many a time, a perimenopausal lady come with us and she told Dr. Saab, now I got a frequent cycle or my cycle will be short or the bleeding is the less. So maybe this is not always pathological. Maybe it happens that she will be attained her menopause in the next 6 months to 1 year. So this menstrual cycle becomes shortened as in the late reproductive age group. There may be the lengthening of the intermenstrual cycle, and some may have the sudden amenorrhea. Now, these are the 4 stages in a woman's life. Premenopausal, usually we consider between 12 to 34 weeks. The perimenopausal, between 35 to 45 year of age. The estrogen level declines and there is a frequent irregular menstrual cycle. Menopause, that is cessation of the menstrual cycle, that is between 46 to 51, and the postmenopause till that is 52 plus till the end of the life. So what is the symptoms? As I already told, the classical symptoms may be change in the menstrual cycle pattern. There may be vasomotor symptoms, usually including the night sweats. There may be vulvo-vaginal symptoms or dyspareunia. The other symptoms associated with the menopause are very frequently the sleep disturbance, that insomnia, the cognitive concern, that the memory loss, or patient usually come, doctor sahab aajkal hum bhool ja rahe hain, whether I keep the things I always used to forget. Previously it was not like that. So maybe see, it's a symptoms of the menopause. Second is the psychological symptoms. The patient may have depression, anxiety, mood swing, or the irritability. So many times the husband came with us and they told ki previously my wife was so sweet, she was so innocent, she never even raised a voice in front of it. I don't know what happened, doctor. Nowadays she is very much irritated. Anytime when I ask her about something good about her, still she is start fighting and all. So these maybe are the symptoms or the early symptoms of the menopause. Now coming to the most important vasomotor symptoms. Now this is actually most important because this is the most common for which the women seek the medical care. The vasomotor symptoms is the sudden sensation of the heat in the face, neck, chest, or which persist for the several minutes or less. During a hot flush, the skin temperature rises due to peripheral vasodilatation, particularly in the fingers and toe. There may be sweating, or heartbeat may be increases by 7 to 15 beats per minute. It may take 30 minutes or longer for the skin temperature to return to the baseline. Coming to duration, I already told that it is in a person, it may be the vasomotor symptoms will take 30 minutes to come to the normal. But when the patient attended the menopause, it may take up to 10 years when the hot flushes, and after 10 years she will relieve from the hot flushes. So why I emphasize this the long duration, because many a time we are not advisable advise patient to have HRT for such a long time. So in that cases, we always advise, and counseling is very important, and we should advise that these hot flashes, it is not at all pathological. It is due to the physiological changes in your hormones, in your body, and it will subside, and it will may take up to 10 years. So nothing to worry. Now the body composition, although women typically gain weight during midlife, but in the early postmenopausal year, women typically gain abdomen fat mass and they lose lean mass. So there is a body deformity is very common in a postmenopausal lady. Now, what is the somatic symptoms? The somatic symptoms are joint acne, pain are the most common. Women who are obese or depressed are more likely to experience joint pain. Also appear to be associated with the menopausal status, with peri and postmenopausal women experiences this joint pain more than the perimenopausal women. Now, this is also very, very, very important. Now, even in my clinic also, patient often a lady came with a complaining of the joint pain, back pain, not relieved by taking medications, by taking painkillers, or by taking the calcium. So in that case, we should advise her for the hormone analysis to detect whether she is the perimenopausal or menopausal, and we should advise her to start with the HRT, so that's the relief of this type of pain. Now the skin changes. The collagen content of the skin and bone is reduced due to the estrogen deficiency. So reduced or decreased cutaneous collagen may lead to increased aging and wrinkle on the skin, forehead, balding, and hirsutism. We will discuss with these type of how to deal with that in our first subsequent slides. Now, genitourinary symptoms. This is also very important. These refer to as the physical changes of the vulva, vagina, and the lower urinary tract that result from estrogen deficiency. It adversely affects the health, sexuality, quality of life of many menopausal women. The prevalence of the urogenital system symptoms in postmenopausal may vary approximately 15 to 20%. And usually patient come with a complaint of vaginal dryness, pruritus, vulva, and dyspareunia, and urinary urgency. Now, this is the same. Now, the physical sign of the vulvovaginal atrophy are variable, which include, I already told, that reduced vulval fat, reduced vaginal rugae, and blood flow, leading to the pale appearance. There is a change, is the acidic media. The moderately acidic ranges to a neutral range in the pH. So there is a shift in the vaginal maturation index. So they are more vulnerable to have the infection. Vaginal lubricants and vaginal moisturizer can be offered for the genital dryness and dyspareunia. The local estrogen therapy is the first line management and only contraindicated being the active estrogen dependent tumors. What are the sexual problem? As I already told, there is a vaginal atrophy with the age, which may lead to dyspareunia, causing the sexual dysfunction, which is corrected by local estrogen therapy. This acquired, the second is the, it may be acquired due to the sexual desire disorder in some women response to the, which may respond to testosterone therapy. But unfortunately, testosterone therapy is not freely available in India for the women. Yes, but for the men, it is present in India. Well, on in this type of situation, give a very good result, and it definitely increases the libido of the premenopausal and postmenopausal lady, so improving their sexual problem. Now coming to the central nervous system, dementia. This is a core mental function are the memory, communication, language, ability to focus, pay attention, reasoning and judgment, activity of daily living, and the visual perception. So it actually, when there is any of two function are impaired, we call it as a dementia. So in menopausal ladies, definitely these functions are affected and may cause dementia. Especially suppose that if the patient is not getting a adequate support, not getting adequate love, tender care from their family members, from their partner, definitely they will lead to dementia. And in HRT, when we are giving, it may be beneficial for them. Even I have seen in my OPDs when the patient came with this type of things, HRT does have a role in improving these type of symptoms. Depression, it is again a significant increased risk of newly onset depression in a women during the menopausal transition compared with their menopausal. The cognitive changes, maybe the evidence support the relation of the estrogen to the cognitive function. Women face problem with the memory loss, difficulty in concentration is very very common in menopausal. So a definitive role of HRT for treatment of these cognitive symptoms without vasomotor symptoms lacking. Now, sleep disturbance is again very important in the peri and postmenopausal women. Sleep insomnia is very common, and there is a more frequent insomnia. And they usually came us with to have, Dr. Saab, I have an insomnia, and please prescribe some sleeping pills, vagara, and different type of sleeping pills. But actually, what we are advising, and we should take the history that whether it is only the sleep deprivation or it's just a symptoms of the menopausal syndrome. Now, the perceived decline in the sleep quality may attribute to generalized aging factor, sleep-related disorder like apnea or other chronic illnesses like chronic pain, depression, stress, negative mood, or definitely ovarian hormone changes. And secondly, the hot places can also trigger awakening in the first half of the night. And so patient may feel and say sometimes they awake in the night and they said, the doctor, I awake because of these hot places, because I feel very hot, and that's why I got a lot of sweating. So this may be patient presenting symptoms. Decision on whether and how to treat with the behavioral or drug therapy or both depend upon the severity of the sleep disturbance or context of the sleep problem, that is distressing hot flush of life stress, severity of the daytime consequences. Now, mood disorder, I already told you that feeling of upset, loss of control, irritability, fatigue, blue moons at the midlife may be caused by fluctuating hormone level that perturb the natural system transition. So in that cases, a history of the premenopausal syndrome is there. There is a significant stress, sexual dysfunction, physical inactivity or hot flushes are more vulnerable to depressive symptoms. The most predictive factor for depression at midlife and beyond is the prior history of the clinical depression. The relaxation and stress reduction technique, antidepressant and counseling or the psychotherapy are options to consider in the symptoms management. Osteoporosis. Again, this is very important. It is defined as the compromised bone strength. I'm not going to tell that what actually that what are the different grading, what is the normal and what is the low. But usually we see, because in India, even in the premenopausal ladies, the calcium reserve is low, the vitamin D3 reserve is low. So definitely in postmenopausal, almost in my 100% patient, when I ask them to go for the calcium level analysis, they are always the reduced, they are always the deficiency in the calcium, and they are definitely the patient of the osteoporosis. So this is very important to treat in a postmenopausal and perimenopausal lady. This low estrogen account for about two-thirds of the bone loss during the 5 to 7 year around the menopause. So what is the risk factor for the osteoporosis? The advanced age, the parental history of the fragility fracture, the female sex, the tobacco smoking, the height. As there is a more height, there is a now again this there is a doubt in that. Again, the few are saying, a few data is saying that because if they are fatty, then the fat is converted to the endogenous estrogen and they give actually protection. But overall, there is definitely osteoporosis is a factor in case of postmenopausal lady. Long-term use of the glucocorticoid again is a risk factor for osteoporosis. Height, rheumatoid arthritis, low femoral neck BMD, higher fragility fracture, alcohol intake more than 3 units daily, and the other cause of secondary osteoporosis may lead to the osteoporosis. Now, the osteoarthritis. Yes, again, this is also very important. Epidemiological study of a potential role of the estrogen in the osteoarthritis, so two different variables that it deprived at the menopausal ladies associated with the increased frequency of knee, hip, and finger osteoarthritis, and in the severity of the hip osteoarthritis. That means the menopause not only cause the osteoporosis, but it also have some role in the osteoarthritis, especially in the long joint. So if the patient is not relieved with the other symptoms and initial symptoms of the arthritis, you may prescribe the lady HRT, and definitely she will benefited with that. Now, the cardiovascular diseases, definitely it's included the coronary heart disease and stroke. It is second leading cause of death in US and leading cause of death for the women more than 65 years. So definitely cardiovascular diseases are at a fourfold increases even in lady with the obesity, diabetes, and hypertension. Now, the cancer, this is again very important. Menopause is not associated with the increased cancer risk, but the cancer rates are increased with age, and cancer is the second leading cause of death in women. So screening of the following cancer is regularly. So there is a clear cut, maybe during menopause these cancers are at an increasing trend, but menopause is not a risk factor for any of the cancers. But in menopausal lady, we should know that there is an increased chance of breast cancer, increased chance of colorectal cancer, definitely increased chance of endometrial cancer, definitely the ovarian cancer. So in a menopausal lady, we should screening all these things, all these cancers, and we detect early, we should advise the patient to go for the screening, go for the treatment. The cervical cancer is, again, I already told, cervical cancer is a bimodal, and the pap smear test should done in every 3 year or every 5 year. If it is combined with HPV testing, after a normal report 3 years in a row for a woman, 550 to 64. That means we should do pap smear every 3 years. And suppose that all consecutive 3 year states turn out to be normal, we should advise pap smear every 3 yearly up to when? Up to 64 year of age. After 64 year of age, with 3 or more normal pap smear tests in a row, then it is not required to do a screening after 65 year, because there is a drastic reduction in the incidence of the cervical cancer after 65 year of age. Sorry. Now coming to the treatment. As I already told you, the treatment and management of menopause is there is a no fixed protocol. It is always individualized. It's depend upon the treatment. It's depend upon the symptoms of your patient. If the patient come with the symptoms of more hot flushes, then the treatment is only pertaining to that. If the patient coming with the symptoms of the osteoporosis, low back pain, joint pain, then the treatment is again the different. So each and every patient should be individualized and their prescription should be different. Now, the most important treatment is the hormone replacement therapy, and definitely I will take this hormone replacement therapy first. This is used to replace the estrogen that the ovaries is no longer make during and after menopause. So the hormone replacement therapy may be either estrogen alone or estrogen plus progesterone. Generally, we use the HRT in a short period of time, that is 3 to 5 years is advised. Reduce in the doses should be done as soon as in the possibility due to the various side effects, which I will tell. Now, is each and every menopausal lady is a candidate for HRT? The answer is the no. Now these are the indications where we should advise for the HRT. Now when we should advise HRT? For relief of the menopausal symptoms, the most common is the vasomotor symptoms or is the cognitive symptoms. The prevention of the osteoporosis, maintain the quality of life in a menopausal years. The special group of women to whom HRT should be prescribed are a lady with a premature ovarian failure or gonadal genesis or surgical or radiation induced menopause. Now, what are the risk factor of the hormone therapy? Endometrial cancer, very important. So the screening of the endometrial cancer should be done. Now, venous thromboembolism, the risk is increased within 1 to 2 years after initiation of the hormone therapy. The breast cancer, it increases the breast density with the estrogen via proliferation of the estrogen dependent mammary gland, making it more difficult to detect the breast cancer early with the mammogram. So it should be in our mind, if the patient is acting on HRT and there is some lump or something, some symptoms regarding with the breast, so we should not only rely on the mammography, because if there is a initial symptoms of the breast cancer, the mammography may be turn out to be a normal due to this HRT. So ovarian cancer, more than 10 years of estrogen therapy, if there, then definitely it increases the risk of the ovarian cancer. Cardiovascular accident, definitely it increases due to increase in the venous thromboembolic disease. Lipid metabolism, there's increase in incidence of the gallbladder benign diseases has been observed following HRT due to rise in the cholesterol in the bile. What a next, now what HRT should we give? We commonly use the estrogen, that is the conjugated estrogen. The doses may vary from 0.625 to 1.25 milligram per day, or progestin used as a medroxyprogesterone. There may be increased consider risk. The hormone therapy should be used with the lowest effective dose for a short period of the time. So usually, which we advise, the oral estrogen level, estrogen, conjugated estrogen at the level of 0.3 milligram daily is effective, and this got the minimum side effect, and we should start. And suppose that we will not get adequate result, then only we should start our therapy, and it should at least take 2 to 3 weeks to get a visible improvement in the symptoms. So after that only we should start or increase our dose of the estrogen. Now the progestin, when there is a history of breast cancer or the endometrial cancer, progestin alone may be used. It may be effective in suppressing the hot flushes, and it prevents definitely osteoporosis. Now the medroxyprogesterone acetate at the a dose of 2.5 to 5 milligram per day can be used, and it is definitely a drug of choice in case of there is a breast cancer or in case of there is a endometrial cancer. Now the Tibolon. Tibolon is a very good medicine. It is a steroid having weakly estrogenic, progestogenic and endogenic property. Prevent osteoporosis, atrophic changes of the vagina, and hot flushes. Now, these three symptoms are very important. So, Tibolon may be used at an ideal drug in case of menopause, where the HRT, whether these type of things are contraindicated, and in the cases where the patient have the sexual dysfunction during the menopause. So the dose should be at 0.5 milligram per day. We can increase the dose up to 5 if it is not relieved. Now coming to these type of non-hormonal therapies, that soy, phytoestrogen, black cohosh, these actually the data what the Cochrane are saying, that these are very weak estrogen supplement, and there is a no conclusive evidence of improvement in the menopausal symptoms even in 43 different trials. So there may be what we also prescribe this type of thing, isoflavine or the phytoestrogen, but maybe there have I seen in my general practice it has a wonderful result, and patient often improve their symptoms. Maybe this is the psychological, but the data is saying that it doesn't improve the menopausal symptom. Now, the ideal menopausal solution, it should be regulate endogenous estrogen to the non-reproductive organ and reproductive organ. It should offer symptoms release as good as the hormone therapy without risk of the cancer, cardiovascular diseases and stroke, which may be associated with the HRT. Now, these are the medical herbs which have shown some promising results, and different type, like in Korea and China, they are saying that yes, their data is saying there is some improvement in the quality of life in dealing with the symptoms of the peri and postmenopausal lady if we are taking this type of combinations. Now therapeutic lifestyle management, this is very, very, very important. The 3-step management of the menopause, that is the right diet, right exercise, and medication per se for the other chronic illnesses like diabetes, hypertension, it should be in a controlled way. She should take adequate diet, adequate sleep. As I previously said, a love, tender care is very, very, very important in case of management of the menopause. The yoga, exercise, they should be there. And nowadays, I already told you, there is a saying, the lady should be fit at 40, strong at 60, independent at 80. These things are very important. Now, the therapeutic lifestyle management is the physical activity, targeted exercise, not like going and doing anything. It should be under supervision, because in this case, in lot of ladies, there is osteoporosis is there, so bones are already weak, and they should train and do exercise under, definitely under supervision. The nutrition, there should be adequate calorie intake, adequate vitamins should be there. They avoid the alcohol, tobacco, stress reducing studies, doing yoga, doing meditation. Now, the massage, hobby, nutrition, emotional stability, positive attitude, family involvement, spiritual attitude, and the sleep. The patient should engage themselves to do whatever they want. They want to do gardening, they should spend their time in doing gardening. They want embroidery, they can do embroidery. Whatever they want, they should involve, and definitely they will involve themselves in doing those type of things, and definitely I think they will improve a lot to counter these type of symptoms. Now, the recommendation in a diet, these all data are from the Indian Menopausal Society. The sugar not more than 6 TSF per day in a in a non-diabetic patient. The salt should be 1.5 to 3 to 5 gram per day. Oil should be 2 teaspoonful per day. Fruit should be 100 gram per day. Vegetables 300 gram per day. They should take adequate drink, adequate fluid, and at least eight glasses of water every day. Add powder of the flaxseed that uh, uh, cinnamon, dalchini, flaxseed is PC, fenugreek uh, is there, in soft, in salad and curd. They are saying that it's contain the natural estrogen, and definitely they improve this type of things. This fenugreek is the methi. Tea, coffee, and dairy products. Avoid more than 200 milligram per day of caffeine. More than 300 milligram per day of caffeine. Limit intake of the tea, coffee to 3 gram per day. 1 cup of brown coffee is equivalent to 120 milligram of caffeine. So we should the caffeine intake should be less than 200, and consume a minimum of 500 to 600 ml of milk or curd, build on the calcium bank in the bone. It is very important. Support it with a lot of vitamin C, that is citric fruits and vegetables, which definitely favors the calcium absorption. Management of osteoporosis, not going in detail of what to do, but definitely this I can see, if the when we are we are doing the analysis for the osteoporosis and it turned out to be normal, then we should follow up every 2 year and later reinforce the lifestyle changes. If there is a osteopenia, there is a no associated risk factor, the same 2 year follow-up. If there is a one major risk factor or more than two other risk factor, no menopausal symptoms, then HRT should be there. HRT, we can advise Tibolon. Bisphosphate is very important in this type of cases. If there is a definitive osteoporosis, the patient, if it is a menopausal symptoms, then HRT, Tibolon, and bisphosphonate is advised. If there is a osteoporosis but no menopausal symptoms, bisphosphonate can be bisphosphonate is the drug of choice in this case. If not improved, we can advise for the HRT. If it is associated with the severe osteoporosis, then definitely bisphosphonate and calcitriol should be given. Now, living with the menopause, nutrition, that calcium intake should be less than 800 milligram per day to 1200 milligram per day. Upper limit of normal is 25 milligram per day. So here just I want to advise, because mostly what calcium we are advising is actually 500 milligram. And many a time the lady doesn't have adequate calcium in a diet. So we should at least advise the calcium which contain this adequate amount of the calcium. Vitamin D, 1500 to 2000 international unit. Upper limit of normal is the 10,000 international unit. Management of the vitamin deficiency, it is the vitamin D tablet once a day for 8 weeks, preferably with milk, or 60 IM injection given to correct the deficiency. What is the maintenance dose? Maintenance dose after 8 weeks, that is after 2 months, it is the 60,000 international unit once a month, once a month or twice a month, once a month in a summer and twice a month in a winter. So the vitamin D supplement by oral spray or tablet may is freely available nowadays, and the dose is 2000 international unit per day. Injection of the cholecalciferol, 30,000, that is 3 lakh international unit IM twice a day, or 6 lakh international unit IM once a year is sufficient. But as I already told, calciferol, vitamin D, we are blessed. We are in India and we get a sufficient amount of vitamin D in our, by exposed to the sun. Use this free calcium, use this free vitamin D. But still, if vitamin D is deficient in your body, we should supplement the patient with this vitamin D. Now, managing the thromboembolic risk with the menopausal hormone therapy in COVID-19 pandemic. Now, in the COVID-19, when I get a lot of patients who are saying, who are actually COVID positive patients, they are associated with this thromboembolic risk factor, and they told ki whether the hormone replacement therapy should be continue, should we start it or should we not. So what at which we advise is, if the patient is an outpatient department and she has a mild symptoms, the HRT should be withdrawn. If there is a persistent respiratory symptoms that required only outpatient management and self-isolation, then the using HRT, we can transfer the switch the patient to the transdermal HRT, and add the prophylactic low molecular dose heparin. Suppose if the patient is the hospital, there is a withdrawal of the HRT, should be systemic HRT should be there, and low molecular dose heparin should be used for the prophylactic dose, because it is always concerned. We know that this low molecular weight heparin is a very important medicine for treatment of the treatment of the COVID. So if the patient is always on HRT, on systemic HRT, on HRT, and we all know that this HRT has a risk factor of the thromboembolism. So in any case, if it is a mild symptom, the HRT should not be withdrawn. But if it is a severe or very severe patient need hospitalization, the HRT can be withdrawn, and we should add low molecular dose heparin, and we can use the transdermal HRT, so those type of symptoms will not revert back. So the take home message is, the target population for the HRT is usually within 10 years of menopause. The HRT initiated in the early postmenopausal periods in healthy women is safe. Like all medicine, hormone therapy need to be used appropriately, but it is essential that women in early menopause who are suffering menopausal symptoms should have the option of using HRT. Right women, right age, right HRT, right dose, and right route is the success of treatment for the menopausal symptoms. That's all from my side. I think this is very exhaustive, and thank you so much for your kind listening.
Thank you very much, sir. Thank you very much for this nice presentation, informative. And sir, meanwhile, I have received few questions. So if you allow me, then
Yeah, definitely, definitely.
sir,
Hello.
hello.
Suman.
Yeah, sir. Sir, my first question is in case of menopausal symptoms, can we use phytoestrogens along with HRT with some reducing dose of HRT? What is your opinion on that?
Look, as I already told, these phytoestrogen, even I am using this type of phytoestrogen, and I have seen that in a mild symptoms, in a it alone, phytoestrogen alone has some effect, and patient always get benefit in case of mild symptoms. But what data is saying, actually, they are saying that it doesn't improve those type of menopausal symptoms. So might be this phytoestrogen has some placebo effect in those patients, but if you are using, you want to use phytoestrogen along with HRT, there is no contraindicated. Definitely not.
Okay, sir. And one question from my side, sir. If patient comes with some these menopause symptoms and having their cardiovascular issue in their medical history, so what will be your choice of treatment on that? Because
Now,
HRT is sometimes
something
creates some
important,
problem.
because definitely
Yes.
this is very important. And nowadays, Suman, I just wanted to tell you one thing. Because most of the patient, because nowadays we know India is now the diabetic capital of
Yes. Yes.
the world. So
Yeah.
we always, in a case of majority of patient with the menopausal symptoms, either they have diabetics, they have hypertension, they have some cardiac issue or something like that. So in this type of case, and if it is definitely, if it is a mild symptoms, those I told you, those phytoestrogens, these are definitely helpful, no doubt about it. Quinolone can be used, and in this case, progesterone alone, that is the medroxyprogesterone acetate, in the initial dose of 2.5 to 5, can be given in these type of cases where the estrogen is contraindicated. As I already told, these we have already discussed about those herbals, those herbs, and I am
Yeah.
using that herbs, and really, I get, even in mild to moderate cases, we the symptoms patient got relief. Along with that, I already told you, not only the medication or the pharmacotherapy, the non-pharmacotherapy is very, very, very important, about the diet, about the understanding love, care, and about doing the exercise, about the patient to engage them to somewhere. I got a patient, and but she has alone, two sons, not very much caring about toward her mother. I told her ki, Mataji, do you have some skill, something you want to make anything? So what
Okay.
she told ki, yes, I can make mombatti, candles.
Okay, sir. Mhm.
So she started making candles, and I am not given any HRT to her. She started making candles, and she is also earning, and her all the symptoms are just vanished. So
Okay.
these non-pharmacological symptoms are, this non-pharmacological treatment is also very, very, very important. Counseling part in these patients are very important, and the counseling should be along with the family members, because many a time I told you na, the son will come कि अरे माँ मेरी झगड़ा करती है, the daughter in law come कि अरे इनको तो इतना इरिटेशन होता है, पता नहीं चीजें रख के कहाँ कहाँ भूल जाती
Yes.
है.
Yes.
And that is and they give the burden. And what happened once, the son-in-law, the daughter-in-law, when they are asking, they blaming the lady, self-estimation decreases. Okay, they got
Yes.
depression, they got other cognitive symptoms. So the counseling is very important, and always give. I advise everybody to give at least few of your time for the counseling of this patient and counseling of the family. It will definitely help in management of menopause in this type of lady.
Okay, sir. And sir, one thing that calcium and vitamin D, whenever you are using in case of osteoporosis, patient in menopause, and obviously with can it be prescribed with HRT?
Yes, you can. You
No
can
issue.
prescribe with HRT. Definitely,
And
you can prescribe with HRT. No,
and
there's no contraindicated. Yeah.
well, what do you think that phytoestrogen has its any benefit on that case?
I told you, na, personally, I am using it and I have seen good results.
Okay, sir.
Okay, though the data I already told, because
Yes.
all R is the evidence-based medicine. Now
Mm-hmm.
it is the evidence-made medicine.
Mm-hmm.
But maybe this phytoestrogen, even I have seen there's a improve in the osteoporosis, and after giving this type of phytoestrogen. Okay, along with
Yes, sir.
just giving phytoestrogen, giving calcium, and they improve their bone pain, joint pain. They improve that their in incidences of this pain, and there is an improvement in the bone density due to this phytoestrogen, and calcium is there. So I think there may be some effect, though data is not say not supporting, but I am using that and I see good results with that.
Yes, sir. And sir, what is your suggestion for the young, means say if it is around 40 years of age of a patient and she is having some menopausal symptoms. So to maintain her sexual health and preservation, what is your suggestion and how do you manage that kind of
Now,
situation?
in case of young patient, if they completed their family, suppose that, okay, so main symptoms along with them are actually the sexual problems. And I have even 2 days back, I got a patient, and with her husband was saying that she has the symptoms of the less desire, and her symptoms, and she has the symptoms of those menopausal. The husband and wife is almost the same age, 37, 38 year. And the wife is almost perimenopausal age group, and she has the symptoms of few early symptoms of the menopause, like dry vagina, and the mood swings and all. So in those cases, first the local estrogen, that is estrogen cream, is very important. Because in case of dry vagina, actually, in the dry vagina, when they go for the intercourse, it causes dyspareunia. So dyspareunia, it is a vicious cycle. Like they have a, let's say unka mood is low, and when they get dysmenorrhea, then their mood is again get low, and they just don't want to be intimate with their husband. So in that case, local estrogen first is very important, and it has some role. And secondly is the tibolol. Tibolol at a dose of 2.5, we can increase to 5 milligram per day. But initial stage 2.5 can given daily for 3 months in a shot, and it definitely it's improved. I have seen it's have improved. And definitely what I told ki the counseling part is very important, and husband counseling should be.
And okay, sir. Sir, one Dr. Pratibha Rai also commented in our platform that the representation is nice and very informative.
Thank you
And
so much. Ma'am, she is president of Dhanbad Obese Society at present, and ma'am is a very senior. She is like a mother figure for me, and she's HOD of our medical college in Dhanbad. Ma'am, thank you so much,
oh,
ma'am.
sir, and I request you, sir, as you are in Foxy Sexual Medicine Committee on Public Awareness. So we want to invite you for some educate clinicians on preserving sexual health in menopausal women as well, sir.
Thank you. Yeah,
So
definitely.
thank you, sir. Thank you very much
Thank you.
for this informative and nice presentation and good discussion as well. So, okay, sir. Thank you very much for your valuable time once again, and we will look forward in future also for this
Definitely.
kind of session with you. So, thank you very much, sir.
Thank you. Thank you. Thank you so much.
Thank,
Thank you so much. Thank you so
thank you,
much.
sir. Thank you all.
Okay.
Sir, thank you, sir.
Thank you, Viplav. Thank you so much. Thank
Thank
you
you.
so much.
Thank you, sir. Thank you.
On
Dr.
behalf
Datto,
of
thank you once again, and good evening to you.